This presentation is focusing on the 2024 European Society of Cardiology (ESC) guidelines for chronic coronary syndromes (CCS) and 2025 ACC/HA acute coronary syndromes (CSS) guidelines. In summary, providing a four-step approach to modern angina management. Outline: Latest Angina Management 2025. Introduction. Definition: Angina is not just pain, it is a symptom of myocardial ischemia and imbalance between oxygen supply and demand, usually due to coronary artery disease, CAD. The shift: modern guidelines focus on chronic coronary syndromes, CCS, rather than just stable angina. It's a lifelong, dynamic process. Goal of therapy: 1. Improve prognosis, prevent MI/death, and 2. Improve symptoms, quality of life. Key 2025 update: move towards personalized, functional testing over routine anatomical tests for low-risk patients. Step 1: Initial diagnosis and evaluation. Clinical history: is it typical retrosternal pressure, brought on by exertion, relieved by rest/nitro? Or atypical? Resting ECG, 12 lead to look for Q waves, STT changes. Lab tests: high-sensitivity cardiac troponin, essential for ruling out ACS, lipid panel, hemoglobin, renal function, HbA1c. Resting echo, to evaluate LV function, ejection fraction, and valve disease. Pre-test probability, PTP. The 2024 ESC guidelines suggest a risk factor-weighted approach to decide if further testing is needed. Step 2: diagnostic testing and risk stratification. Very low risk, less than 5% defer testing, manage lifestyle. Low to moderate risk, coronary CT angiography, CCTA, is now first line to rule out obstruction. It is superior for detecting non-obstructive plaque. Moderate to high risk, functional imaging, stress echo, SPECT/PET, or cardiac MRI, to assess ischemia, how the heart works under stress. Invasive coronary angiography, ICA, reserved for high-risk patients, refractory angina, high-risk non-invasive findings. Step 3: medical treatment, the pillars. Disease-modifying, prognosis. Statins, high-intensity therapy aimed at lowering LDL cholesterol levels. Antiplatelets, aspirin or clopidogrel to reduce thrombotic events, guided by patient tolerance. ACI/ARBs, for hypertension, diabetes, or reduced ejection fraction, EF and LT, 40%. SGLT2 inhibitors/GLP-1 agonists, if diabetes is present, regardless of HbA1c. Colchicine, used to reduce major adverse cardiovascular events, MACE. Anti-anginal drugs, symptom relief. First line, beta blockers, bisoprolol, metoprolol, or calcium channel blockers, DHP for combo with BBs, non-DHP if no BBs. Second line, ranolazine or long-acting nitrates, ranolazine is favored due to less hypotension. Refractory, ivabradine, if HR more than 70, or trimetazidine. Step 4, revascularization and long-term management, 8:30 to 10:30. Revascularization, stenting/bypass indicated if symptoms persist despite optimal medical therapy, or if high-risk stenosis, and GT than 90% or FFR less than or equal to 0.80, is found. CABG versus PCI, CABG is generally preferred for 3-vessel disease plus diabetes. Lifestyle: mandatory smoking cessation, Mediterranean diet, 150 plus minutes/week, moderate exercise, weight management. Rehabilitation: cardiac rehab programs are highly recommended. Emerging concepts and conclusion. INOCA/ANOCA, ischemia/angina with no obstructive coronary arteries. Requires testing for microvascular dysfunction. Digital health, using wearables for heart rate/rhythm management. Key takeaway: personalized, evidence-based care reduces heart attacks and improves life quality. Acute angina pectoris requires immediate medical intervention to restore blood flow to the heart and prevent a heart attack. If you or someone else is experiencing sudden, severe chest pain, call emergency services immediately. Medical professionals typically use the following medications for acute relief and stabilization. Immediate relief, rescue medication. Nitroglycerin, short-acting. This is a primary treatment for an acute attack to help dilate blood vessels and improve oxygen delivery to the heart. Protocol: it is typically used at the first sign of pain, with usage instructions determined by a healthcare provider, often involving repeated administration if pain persists. Aspirin, antiplatelet, used to help prevent further blood clotting. Administration: non-enteric-coated aspirin is often recommended to be chewed for faster absorption. Hospital-based acute management. In a clinical setting, healthcare providers administer additional medications to stabilize the patient. Anti-ischemic agents. Beta blockers, e.g., metoprolol, these are used to slow the heart rate and reduce cardiac workload. Calcium channel blockers, e.g., diltiazem, these may be used if beta blockers are not tolerated or for specific types of angina, such as vasospastic angina. Anticoagulants, medications like heparin or bivalirudin are given to prevent clot propagation. Statins, high-dose statins, e.g., atorvastatin, are often initiated early to stabilize arterial plaque. Pain management, medications such as morphine may be used if nitroglycerin does not sufficiently relieve pain. Critical safety warnings. Erectile dysfunction, ED, drugs. Do not take nitroglycerin if you have used ED medications, e.g., Viagra, Cialis, within the last 24 to 48 hours, as this interaction can cause a fatal drop in blood pressure. Positioning: it is advised to sit or lie down before taking nitroglycerin to prevent falls from sudden lightheadedness or low blood pressure. A sample: fictional doctor's prescription for educational purposes only. This is not medical advice, and you should never use it for actual treatment. For real health concerns, please consult a licensed physician. Sample prescription: acute angina pectoris, fictional example. Patient name: John Doe. Age/sex: 54/male. Date: February 3, 2026. RX: nitroglycerin 0.4 mg sublingual tablet. Dosage form: tablet, sublingual. Frequency: 1 tablet under the tongue at onset of chest pain, may repeat every 5 minutes as needed, up to 3 doses in 15 minutes. Aspirin 81 mg chewable tablet. Dosage form: tablet, chewable. Frequency: 1 tablet once daily. Metoprolol tartrate 50 mg tablet. Dosage form: tablet, oral. Frequency: 1 tablet twice daily. Isosorbide mononitrate 30 mg extended release tablet. Dosage form: tablet, extended release. Frequency: 1 tablet once daily in the morning. Special instructions. Avoid sudden discontinuation of beta blockers. Keep nitroglycerin tablets in original container, away from light and moisture. Seek emergency care if chest pain persists after 3 nitroglycerin doses. Doctor's name and signature: Dr. A. Sharma, MD. Registration No. 123456. Clinic address: 123 Health Street, City. Sources and references. 2024 ESC Guidelines for the Management of Chronic Coronary Syndromes, European Heart Journal. 2025 ACC/HA/ACP/NAMSP/SCAI Guideline for the Management of Patients with Acute Coronary Syndromes. Management of Angina Pectoris, Science Direct, 2025. Angina, Diagnosis and Treatment, Mayo Clinic. Disclaimer: this is for informational purpose for doctors only. Please consult your doctor/guide for exact details and verification before acting on it.